Hello, everybody. My name is Jenna Sorgenfry, and I am the current PGY2 Critical Care Pharmacy resident at Prisma Health Upstate. Today, I'm presenting my research on dexmedetomidine to facilitate successful extubation in agitated mechanically ventilated patients. Myself and the other individuals involved in this research have nothing to disclose. According to the Society of Critical Care Medicine PADIS guidelines, 50 to 80% of ICU patients experience agitation, which is associated with delirium, and both of these have several possible consequences, some of which are listed on the slide. In mechanically ventilated patients, the approach to extubation is to decrease sedation, perform a spontaneous breathing trial, and extubate if they pass. However, in patients with delirious agitation, weaning sedation can lead to increasing agitation, making extubation unsafe or unsuccessful. This is where dexmedetomidine may be useful, as it provides a bridge to extubation, with lesser respiratory depression and sedation than traditional agents. The previous literature supporting dexmedetomidine for this indication is limited, with very small sample sizes, but all studies showed significantly better outcomes, such as a decrease in time to extubation and an increase in ventilator-free hours with dexmedetomidine use, which led to the 2018 SCCM PADIS guidelines to suggest dexmedetomidine in ventilated patients where agitation is precluding weaning, but it was a conditional recommendation due to a low quality of evidence. Which leads me into my research study. The purpose of this project was to determine if the addition of dexmedetomidine to the ICU sedation protocol in the 24 hours leading up to extubation in agitated patients increases the overall ventilator-free hours in the 7 days after the first extubation attempt. This study was conducted at Prisma Health Upstate's main campus, Greenville Memorial Hospital. We are a large academic medical center with 6 adult ICUs and over 100 adult ICU beds. This study was a single-center retrospective cohort that included agitated patients receiving the ICU sedation protocol with or without the addition of dexmedetomidine in the 24 hours leading up to extubation between August 2017 and September 2020. The 24-hour timeline is due to the restrictions of dexmedetomidine at this facility. Currently, dexmedetomidine is restricted to agitated ventilated patients where extubation is anticipated in the next 24 hours, with a maximum duration of use of 72 hours per patient per encounter. To define some study terms, our groups were dexmedetomidine plus the ICU sedation protocol versus the ICU sedation protocol on its own. The ICU sedation protocol includes primary sedation with either propofol, midazolam, or lorazepam. And lastly, agitated patients were defined based on a positive RASS score with either the use of restraints or the use of any antipsychotic or benzodiazepine for agitation. The primary outcome was ventilator-free hours in the 7 days after first extubation attempt, with secondary outcomes assessing hospital and ICU length of stay and mortality, as well as the incidence of bradycardia or hypotension requiring vasopressors. All statistical analysis was performed by a statistician. A total of 200 patients were included in this study, and there were some significant differences in our baseline characteristics. There were significantly more males in the dexmedetomidine group, and patients in the dexmedetomidine group had a significantly higher BMI at baseline, although there were no differences in indication for intubation, with the primary reason being neurologic in both groups. Continuing with patient demographics, I want to mention that the majority of the included population required restraints, though this is likely a result of the chosen definition of agitation in this study, which included use of restraints. In addition, patients in the dexmedetomidine group received significantly more antipsychotics in the 7 days after extubation, but significantly less benzodiazepines in the 24 hours leading up to extubation. Figure 1 shows the primary outcome of this study, which was ventilator-free hours. This was not statistically significant between the two groups. However, one may consider 14 hours a clinically significant outcome, especially if it led to a decrease in ICU length of stay, though that was not the case in this project. There was also no difference in the overall rates of reintubation between the two groups. Here we are looking at our secondary outcomes, with significantly longer ICU and hospital length of stay in the dexmedetomidine group, though with no differences in mortality. And lastly, looking at the incidences of bradycardia and hypotension. There was significantly more patients in the dexmedetomidine group that experienced bradycardia in the 24 hours leading up to extubation though significantly less patients were hypotensive requiring vasopressors. In conclusion, there were no significant differences in ventilator-free hours when dexmedetomidine was added to the standard ICU sedation protocol, and patients in the dexmedetomidine group had longer ICU and hospital length of stay as compared to the control group. I do want to point out, though, that the majority of patients in the dexmedetomidine group, 81 of the 100, had an average low dose of dexmedetomidine, indicating that doses may not have been fully optimized to see a benefit, although dose titration was likely limited by the incidence of bradycardia. There are several limitations of this study. Given that it was a retrospective cohort, we are limited by what was documented in the electronic medical record. In addition, since prior to admission medication reconciliations are not consistently completed on ICU patients by pharmacy, I was not able to accurately assess if the use of an antipsychotic or benzodiazepine were part of a patient's home regimen versus a new addition during their admission. I also did not collect the use of analgesic medications, and although analgesic medications are not used for sedation, they may have influenced the overall sedation picture of the patients. And lastly, there were several potential other causes of bradycardia or hypotension that were not accounted for. Currently, there are ongoing discussions with our critical care attendings to evaluate the utility of continuing to use dexmedetomidine at our facility, given the lack of benefit shown in the study. I am working to assess any differences in our clinical outcomes based on service to help in determining if there is an ideal patient population that may benefit from dexmedetomidine use. Though I do believe a large prospective trial will help to finally answer the question if there is any utility in dexmedetomidine in ventilated patients with delirious agitation. I'd like to acknowledge the following individuals for their assistance in this research. And to wrap up this presentation, the objective of this project was to determine if dexmedetomidine helps to facilitate extubation in agitated, ventilated patients. The self-assessment question is, what is the most common adverse effect of dexmedetomidine? And this study showed us that bradycardia is our most common adverse effect, as 43% of patients in the dexmedetomidine group experience bradycardia. And this overall incidence of bradycardia may have limited the dose titration of dexmedetomidine. Thank you for your time and attention. I would be happy to answer any questions you may have.